Greetings from London. Welcome to the start of London Global Cancer Week. My name is Professor Frank Chinagwundo. I'm a consultant urological surgeon based in London. I'm also Vice President for Europe of AORTIC. Just before we start the program, we have a message from the National Health Service UK Cancer Director, Dame Callie Palmer.
Hello, I'm Callie Palmer, National Cancer Director for NHS England and Improvement. It's my great pleasure to welcome you to London Global Cancer Week 2020. The aim of London Global Cancer Week is to really focus on improving survival in low to middle income countries so that we can make a difference to people experiencing cancer and the effects of cancer around the world, and together help to improve survival. I'm delighted that the UK has played a leading role in convening London Global Cancer Week this year. There are going to be 24 virtual events running from Sunday the 15th through to Friday the 20th of November, really focusing on action and practical steps to help improve support for people around the world. Thank you for joining. We have a number of organisations contributing, including WHO and the Commonwealth. It's a fantastic collaboration of people and teams to help us all make a difference. And I really look forward to hearing the outcomes of the week, and I'm sure it'll be inspiring, moving, and a really important week for all of us. Thank you.
So moving on, I'd like to introduce our first speaker, Dr. Bello Abubaker. Dr. Abubaker is the Chief Consultant Clinical and Radiation Oncologist in Abuja in Nigeria, and he's the current president of the African Organization for Training and Research in Cancer, otherwise known as AORTIC. Dr. Bello Abubaker has a special interest in breast, prostate and colorectal cancers and AIDS-related cancers. He's a principal investigator for many studies, both within and outside Nigeria. So I'd like to welcome the president of AORTIC to deliver his talk.
Hello and welcome to the London Global Cancer Week, the AORTIC segment. I am Dr. Bello Abubaker Mohammed, and I'm the president of the African Organization for Research and Training in Cancer, and I will be talking on cancer treatment in COVID-19 pandemic, the Nigeria experience. So looking at the cancer statistics for Nigeria, according to Globacom in 2018, there were a total of 115,950 new cases. Out of that, breast cancer, cervical cancer, prostate cancer, and colorectal cancer account for almost 50% and more of the prevalence. And looking at it critically in terms of the number by gender, in prostate cancer account for 30% of the male cancers in Nigeria, while breast cancer and cervical cancer account for almost 60% of all the cancers in female. So if we are able to tame prostate, breast, and cervical cancer, we would have been dealing with 50% of the cancers that are easily found in Nigeria and indeed in sub-Saharan Africa. And we do know that cervical cancer is in fact a preventable disease. So if we are preventing cervical cancer in Nigeria, we will be reducing the incidence of female cancers by over 20%. Looking at the COVID incidence in Nigeria, which started around the month of March, there was a steady rise in the disease prevalence across the country, and indeed across the continent, so that by the month of April, there was a lockdown in some states, namely Lagos State and Federal Capital Territory, Abuja. And of course, a couple of other states around Lagos, like Ogun State and Oyo. And because of the lockdown, patients were unable to present to their hospitals, and partly because they need to travel a long distance to go to their hospitals to access cancer care. So that impacted negatively on the patient. So what are the factors for a better survival from cancer? Basically, we need to have a very good health system. And do we actually have that? Looking at the primary health care, where you will want to have vaccination against preventable diseases such as cervical cancer, the human papilloma virus vaccine is known to prevent the cervical cancer, and so also hepatitis B vaccine that prevents the liver cancer. So are those things in place? And the answer is no. Secondary health care, early recognition of symptoms and good referral systems. Most of our secondary institutions are not equipped to recognize diseases early, and there are very few doctors that can actually recognize cancers and send them to tertiary institutions. And for a tertiary institution or a tertiary healthcare to have a better cancer treatment, you will require the following: capacity, that are clinicians to make proper diagnosis, recognize symptoms, the right imaging, proper biopsy, and excellent pathology reporting. We also need equipments for diagnosis such as CT, MRI, bone scans, PET CTs, etc. We need a robust surgical oncology team with multidisciplinary approach. We also need functional and adequate radiotherapy machines such as linear accelerators, brachytherapy equipments. Let me hasten here to say that Nigeria requires about 200 linear accelerators according to the WHO recommendation. We have less than 10 in the country. We also need medical oncology team with sustainable supply of cytotoxic, biologics, and immunotherapy. All these are factors for better survival from cancer, and even before the advent of COVID-19, we've had issues related to them. So how have we been managing cancer during the COVID-19 in Nigeria? Initially, we had COVID-19 anxiety and fear from both patients and the clinicians. So few patients were coming to clinics and follow-ups because they are scared of the hospital environment, believing that COVID-19 is primarily contacted in hospitals. More frequent calls and text messages from patients directly to their attending oncologist were quite high, causing a lot of fatigue to the oncologist. There was several skipping of treatments because of what I have mentioned. Patients were coming from far away distance, and because of the lockdown, they are unable. There is no proper network of transport of patients from rural areas to their treatment centers. There was an absence of PPE at the beginning of the COVID pandemic, raising anxiety and fear among health workers. In fact, many health workers got infected and some even died of the disease. But later on, PPEs became so very much available. Guidelines involving social distancing, face masks, sanitizers, and hand washing became available in the middle of the pandemic. So ab initio, there were no institutionalized guidelines. And there had been a dwindling supply of cytotoxic and biologics across the continent, and including Nigeria. Due to the lockdown, most of our drugs are coming from abroad because we don't have a robust pharmaceutical industry that manufacture cytotoxics across the continent. So by June, Nigeria recorded 745 cases in 24 hours, which was the highest. And it was at that time that we recognized that lockdown may not be the answer to stopping the community spread because of the real economic impact on people. People were unable to eat, people were unable to just stop at home, and there was no palliation and there was no support. Many people live on daily wages to survive. 76% of the Nigerian population live on less than $1 a day, and as a result could not contain lockdowns. The poor health system that are unable to stand alone without external supplies became very glaring. So there was an urgent need for supplies of cytotoxics and biologics from outside the continent for us to be able to sustain our patients, and that was not happening. And we believe countries must look inwards to develop capacities in pharmaceuticals. So Nigeria is providing support to the industry to provide drugs on the essential list. What is the prevalence of COVID now in November 2020? There is a steady rise in the last 2 weeks of COVID, and Nigeria may be facing a second wave, just like most countries around the world. This is because the lockdown is no longer in place and people are traveling around the world, bringing possibly some form of infection from other countries. We recorded 94 new cases on the 9th of September, which is one of the highest. In fact, as of yesterday, there were over 118 new cases with 19 deaths. So what do we really know about cancer and COVID-19? So the main lesson that we might deduce is that standard oncology care should be offered if feasible, including chemotherapy administration. And we had a couple of questions that are yet to be answered. One of which is, will COVID-19 negatively affect oncological treatment? Or on the contrary, might anti-cancer therapy be protective against the cytokine storm caused by the SARS-CoV-2? Are disease stage and status important for those interactions? These are unanswered questions. So we strongly encourage continuation of research that will add the pieces to the complex COVID-19 puzzle and the disease interactions with cancer and cancer treatment. So we must prepare for the future. We must establish standard guidelines for the management of cancer patients in COVID-19 pandemic and beyond. A lot of countries are now trying to establish good recommendations, and South Africa is indeed leading the way. We must reach out to the African Union to recognize cancer as a pandemic in the continent and take all the necessary steps to mitigate them. AORTIC, in collaboration with other organizations such as AMCON, are leading and taking the story to the African Union. We should encourage all the clinical trials being conducted across the continent for a cure and vaccine that is really, really African. What are our recommendations? COVID-19 pandemic has channeled most of our health resources to the treatment of the infection. So there must be a concerted effort to develop and to provide resources for cancer treatment. Already, Nigeria has developed what is called the Cancer Health Fund, that is supposed to be used for indigent cancer patients that have cervical, prostate, or breast cancer. And we recognize that most cancer patients are at risk of mortality if infected with COVID-19. Hence, the urgent need to provide more cancer treatment centers to reduce crowding in our hospitals. Already with the easing of the lockdowns, a lot of our hospitals are already overcrowded, causing possible second wave of the pandemic. And we believe that the African Union must also develop a plan to support member countries. In conclusion, the COVID-19 pandemic has exposed the weakness of the health system across the globe and indeed Nigeria. We must work towards strengthening our human capital and other resources for optimal cancer care across the country. And the time to start is now. Thank you for listening and have a good morning.
Thank you very much indeed, Dr. Bello Abubaker. That's a very, very good start to this London Global Cancer Week, in which you've outlined the Nigerian response to the COVID-19 pandemic. Are there any questions for those who want to answer a question? If you could unmute yourself and then say who you are and where you're from, and then put the question. We can probably take 2 questions.
I think there's a question.
There's a question in the chat.
In the chat, yes.
From Kabelo Udu.
Yes, yes.
Dr.
So
Bello?
he said, can I take it?
Yes, please. Take that.
Okay, so he said, thank you so much for the presentation. You mentioned building capacity with regard to production, manufacture of pharmaceuticals. Where do we start as a continent? We have seen countries like Bangladesh transform their healthcare provision by doing this. However, we seem to lag behind as a continent. I do not necessarily subscribe to the notion of skill shortage, but the challenge still remains and need a sustained solution. Kabelo from South Africa. So I think what AORTIC is trying to do, basically of engaging the African Union, like I mentioned with so many other organizations, is the right direction. We can't continue, importing drugs and equipments into Africa. We must be able to develop them within Africa. That is the only way. And that's the way Bangladesh was able to get to where they are. If we don't do that, then we will continuously have challenges. I mean, this may not be the last of pandemics that we are going to see. And as long as we don't develop capacity ourselves, then we will run into trouble. And the role of the diaspora is very critical here. We have, Africans have a lot of best brains around the world. And we need to engage them to be able to come back home and develop capacity. It is the only way. I mean, they have done so well outside Africa. They should be able to come back and support the people that are working in Africa. And governments must be engaged. We must engage the governments across Africa, and that's the only way. Already in Nigeria, they have developed some resources for development of pharmaceutical industry. People are getting a very soft loan to be able to develop some of these capacities. And I think that's the way to go.
Thank you very much indeed. We're going to now move on to our second set of speakers. Thank you very much, Dr. Bello, for an excellent start. Our next speakers are from the States. We've got Dr. Yehoda Martei, who's an assistant professor of medicine at the University of Pennsylvania. She trained at Harvard and Yale and did her MSCE in clinical epidemiology at the University of Pennsylvania. And the other speaker is Tara Rick, who is a physician assistant with 15 years of experience. And she's currently a PhD candidate at Erasmus University. So I welcome Yehoda and Tara to deliver their presentation.
All right, thank you so much for the invitation to present here. Tara and I will be talking about the impact of COVID-19 on cancer care delivery in Africa. And these are the results of a survey we just conducted between June and August to look at the impact of COVID-19 on cancer care in the region. So we're going to split this into two. I'm going to give you a little bit of introduction methods, and Tara is going to talk about most of the results and some of the discussion points that we wanted to highlight from our study. Before we go ahead, I wanted to acknowledge that this has been a huge multi-collaborative effort. And I want to thank especially these group of people from different countries in Europe and the US and Africa for their input and advice and participation in the study. And it's definitely been a huge success having multiple different people on board. So just a little bit of an overview of the distribution of COVID-19 new cases globally. And so we do know that the number of cases are increasing globally, and this shows sort of which regions are contributing hugely to the number of new cases. And so if you've been watching the news, you know, a lot of the cases are coming from the US and then also from Europe. But if you look closely, you can see sort of the green areas, which highlights the uptick of new cases in Africa, actually. And so I just wanted to highlight this, that new cases are going up. It is still a very relevant pandemic in Africa. And if anything at all, unlike the low cases we had initially at the beginning of the pandemic, it looks like there's been an uptick of cases. And this bar is to just highlight when you look at our numbers, noting that this period is when we actually conducted our study. And so as you may be aware, the number of new cases now is over 46 million, and more than 1.2 million deaths have been recorded due to the pandemic. So COVID-19 has disrupted cancer care delivery globally, and this is very well known now about its impact on NCD care. And so over here on the A side is where we are, where, you know, resources dedicated to controlling the pandemic have really been, have weighed heavily and disrupted cancer care. And so there's less of an emphasis on continuity of cancer care now. And the goal is to shift to a more balanced view where we're able to effectively control the pandemic, but then also can manage to continue care for our cancer patients and avoid adverse effects later on. But then I think I should point out that Africa, on top of the pandemic, has been facing a cancer care crisis for a while now. And this is just a graph to illustrate sort of what the case fatality has been for the Afro region for cancer. And so the blue bars represent incidence and the red bars represent mortality. And so when you look at Europe and the Americas, the red bar is only a fraction of the blue bar. And so a lot of the patients, vast majority of patients who are diagnosed with cancer do not die from their disease. However, when you look at the Afro region, these curves are almost overlapping. And so a huge proportion of patients who are diagnosed, which is the blue bar here, will end up dying from cancer. And so there's the increased burden of cancer mortality at baseline in Africa. There's also studies to show that the cancer workload in terms of the number of oncologists available is actually disproportionately lower in Africa. And so you have several significantly higher percentage of oncologists seeing more than 500 consults a year. And so what we have here with a pandemic is really a crisis within a crisis. And the question is, what is the impact of COVID-19 going to have on an already constrained resource setting for cancer care? So we conducted the study to answer a few specific aims. We wanted to look at the scope of COVID-19 and cancer care specific response strategies employed by African countries. We wanted to examine the distribution and clinical outcomes in cancer patients who've been diagnosed with COVID-19. And then we wanted to explore myths and misconceptions about the virus that physicians are confronting on the continent. If you've heard me speak before, we had an aim for which was to look at the impact on the well-being of providers. We don't have the results of these yet, but we hope to present that at a later date. I think we have some interesting results there, but we won't talk about that today. So this is a cross-sectional web-based survey. We anticipated 150 participants, and as you would see, we enrolled much less. The inclusion criteria was really any cancer care provider in Africa, and we recruited using the AORTIC listserv. So this is the African Organization for Research and Training in Cancer listserv that has about 40 African countries represented on there. And then we used snowball sampling methodology, which allowed people to complete the survey, but then also share the link on their social media platforms. Our data analysis was really mostly descriptive statistics, and I'm going to go ahead and present some of our results now. And so this is the flow diagram of our study participants. So all participants who initiated the survey, the size of that population was 122. So we had 122 who actually initiated the survey, meaning they picked a preferred language in which they wanted to answer the survey. But unfortunately, 16 of those people did not proceed to the consent page. And it's unclear to us why, whether it was related to connectivity issues or other issues. We are unable to tell. So 106 consented, but then out of those, 27 did not provide any survey data. And so the results that we're going to present here today are really based on 79 participants who either provided full or partial data that we've included in our analysis. And these 79 participants represent 19 countries in Africa. As you can tell from the color coding here, areas where we had more than 10 respondents per country were Nigeria and Zambia. Botswana and Zimbabwe actually contributed a lot of participants as well to the study. Most other areas had 1 or 2 participants per country. So demographic and practice characteristics. So most of the participants were slightly more than half were female. We had mostly young patients, 31 to 50 were youngish patients. The survey was available in English, Portuguese, and French, although most people completed the survey in English. And over here, you can sort of see sort of the distribution. There's a lot of heterogeneity in who completed the form, but most people were MDs, and most practice sizes were less than 3,000 patients, oncology, cancer patients seen per year. So COVID-19 general response strategies was sort of the same as we've seen in other countries. So education, social distancing, hand hygiene, mask mandate, and national and regional lockdown. So I wouldn't really delve into that, but majority of countries actually employed these standard non-pharmacologic interventions for COVID-19 control. Specifically looking at oncology response strategies, there were similarities in terms of provider-facing strategies and patient-facing strategies. Again, social distancing, mask mandates, and temperature screening for all patients. This was similar for providers as well, having temperature screening, social distancing, and mask mandates. I wanted to point out that what was really interesting is that you're starting to see some innovation in terms of provider-facing strategies. And so some countries like Rwanda were using drone delivery services, either for obtaining sample collection, or delivering cancer medications, which is great to see. There were also countries that were using courier services actually to deliver medications to the home of patients where feasible. And then there's also the use of telemedicine was actually more common than we expected in the region. I'm going to pass over now to Tara.
Thank you, Yehoda. So this slide highlights how COVID mitigation strategies have affected cancer therapy delivery. Many cancer centers implemented several therapy modifications shown on this slide. And as you can see, many of these modifications centered around delaying visits or reducing the number of visits. For example, nearly 70% reported a postponement of routine surveillance visits and 30% reported delaying new patient visits. There were modifications in all modalities of cancer treatment as well, including chemotherapy, radiotherapy, surgery, and palliative care. Again, a majority of these modifications were delays. For example, delaying palliative chemotherapy or non-emergent palliative radiotherapy, delaying surgery for patients with low risk of progression, or delaying inpatient hospice referrals. Another modification reported was an increase in the use of hypofractionated radiotherapy to reduce the overall number of visits. Next slide, please. So, although almost all cancer centers remained open, 3/4 of respondents reported their centers had reductions in patient volumes, primarily due to fear of exposure, travel restrictions that were implemented during lockdowns, and facility-led interventions to reduce the number of visits as discussed on the last slide. Next slide, please. Oh, sorry. In regards to resource shortages, staff shortages at cancer centers were reported by nearly 60%. The two top reasons for staff shortages were isolation and quarantine and fear of contracting the virus. 3/4 reported a shortage of PPE. Most reported they had access to surgical masks and gowns. However, less than half had access to other PPE such as goggles, face shields, gowns, and N95 masks. 30% reported only access to cloth masks, and 11% were obligated to provide their own PPE. Other resource shortages reported during the pandemic were cancer medications and analgesics shortages. This slide captures clinician perspectives on the number of COVID-19 cases and deaths in patients with cancer at their institutions. Most reported 25 or fewer confirmed COVID-19 cases and 5 or fewer deaths among patients with cancer. Otherwise, many reported no known COVID cases or felt like they were unable to quantify. However, it is important to mention that 10 institutions had multiple respondents who provided data, and in some of these cases, there were discrepancies in the individual institutional level data. The most common COVID-19 related misinformation that oncology providers confronted amongst their patients were that Africans were less susceptible to the virus and that COVID-19 is less infectious in the African heat. Many also reported that the utilization of traditional remedies and the belief that strong faith can ward off the virus. Potentially harmful beliefs were that ingesting alcohol or bleach could be beneficial. Thus, we have seen that African countries have implemented common mitigation and suppression strategies listed here that are observed globally. However, it has been reported that some countries have employed more severe measures such as state of emergency declarations and military enforced national lockdowns. Our data reports few numbers of COVID-19 cases overall amongst patients with cancer and even fewer deaths, which may reflect successful implementation of these strategies. But experts are still divided over whether the low number of cases and deaths reflects successful control and environmental factors versus incomplete case enumeration. Regardless of the reasons, our data highlights the disruptions in cancer care delivery for patients on the continent, which already has some of the highest case fatality rates due to cancer globally. The frequency of delays and disruptions of all modalities of treatment are concerning for long-term adverse impact on disease-free and overall survival among cancer patients. In addition, the pandemic has worsened resource shortages. PPE shortages are not unique to Africa during this pandemic, as supply chains have been stressed globally. However, up to 1/3 of participants, a critical workforce, were without the most basic access to PPE, gloves, and surgical masks. The pandemic has also caused a worsening shortage in oncology workforce. Not previously reported is how the role of fear of virus transmission is contributing to staff shortages, especially where PPE shortages are widely reported. However, the pandemic has presented opportunities for inspiring innovative solutions, such as utilization of drones that are tailored to the healthcare systems in Africa. This technology leapfrogging, although cost effectiveness is unknown, may serve as a blueprint for expanding care and preparing for future pandemics. Our study has several limitations. First, the anonymity of the study limited our ability to control for multiple responses. However, it was clearly stated in the instructions and consent that this was to be completed once per participant. Second, the small sample size, the disproportionate representation of countries, and the potential for selection bias by using professional society listservs limits the generalizability of our results to all African countries. However, our results are consistent with a recent publication from 54 cancer institutions, mainly from Northern Africa, recently published in JCO Global Oncology. Lastly, the discrepant institutional data that was already discussed suggests that staff do not have access to a centralized database of institutional data, and reports of COVID-19 cases may be estimates and anecdotal, thus limiting their reliability. In conclusion, this study shows that the direct effect of COVID-19 in patients with cancer in Africa may be low. However, there has been substantial disruptions in all modalities of cancer care, which may lead to indirect effects such as worsening cancer outcomes. As data continues to expand, there is an enormous capacity to learn from the successes, failures, and tailored innovative solutions to formulating effective policies that minimize harm to cancer patients and staff by this pandemic and future pandemics. We want to thank AORTIC for their contributions, as well as all the study participants for taking time to take the survey during such a challenging time. Thank you very much for attending this session. Our contact information is on the slide, and Dr. Martei will be available after this recording for questions. Thank you very much.
Thank you.
I was introducing our next speaker, Kwanele Asante from South Africa. She's a lawyer and bioethicist. She's the Secretary Treasurer of AORTIC, and she's the former chairperson of the Ministerial Advisory Committee on Cancer Prevention and Control in South Africa. So thank you for being present with us, Kwanele. We look forward to your presentation.
Thank you, Professor Shinogunda. Good morning, everyone. It's my great pleasure to participate in this London event on Cancer, London Cancer Week. Today, I'm going to be talking to you about the ethical and legal issues that happen because of COVID, to cancer patients because of COVID. COVID-19 pandemic has exposed the gaps in health services that require urgent attention in many African countries. COVID-19 pandemic also has underscored the fact that health is a fundamental human right and that its realization and fulfillment is not just for the health of individuals, but for the health of all of society. Therefore, the right to health needs to be critically defended at this time in our global history. The right to health, its genesis, it was first articulated in the preamble of the WHO Constitution in 1946. So we can see that the notion of access to the highest attainable standard of health for every human person without discrimination has been with us for a very long time. The scope of the right and its content was clarified in Article 12 of General Comment 14 of 2000. Furthermore, the right to health is contained in the UN Sustainable Development Goals, such as SDG 3 and SDG 3.4, which speaks directly to curbing the premature mortality from NCDs like cancer by a third by the year 2030. At African regional law, the right to health is provided for in Article 16, Article 16 of the African Charter of Human and People's Rights. And it is framed as the right of every individual to enjoy the best attainable state of physical and mental health. Article 16 places obligations on African Union member states, obligations like that they must take the necessary measures to protect the health of their people. Article 16 also compels African Union state members to ensure that medical services, goods, and facilities are available, accessible, adequate, and of good quality. Both at regional and international law, the right to health places three types of obligations. First, the obligation to respect. In terms of this obligation, state parties are required to refrain from interfering directly or indirectly with the right to health. That is to say, they cannot deny or limit access to healthcare services, health information, etc. And I want us to pause and just reflect how non-COVID services have been interfered with, I would argue, during the lockdowns and during COVID prioritization, where other diseases fell backwards. But going on to the second state duty in terms of the right to health, it requires that state parties prevent third parties from interfering with the right to health. That is to say that you must ensure that privatization does not constitute a threat to the availability, accessibility, acceptability, and quality of healthcare services. The final obligation is that state parties must fulfill this right to health obligation. And they must, in this regard, the duty to fulfill means they must adopt appropriate legal, administrative, budgetary, judicial, promotional, and other measures to fully realize the right to health. Excuse me. Now I want us to pause a little bit. We have seen from all the presentations that came before me that there have been interferences with the rights of people living with cancer. That their right to health has been undermined by the responses to COVID. For instance, taking my country, South Africa, as an example, NCDs like cancer were not included as part of the essential health services in the national COVID-19 response. And as a result, NCD services, especially for people living with life-threatening diseases like cancer, have been severely impacted. We saw it in the other presentations before mine. In Gauteng province, which is the economic hub of South Africa, major hospitals that traditionally treated NCDs were converted into COVID-19 hospitals. There have been delayed, incomplete, interrupted cancer services. For instance, chemotherapy, radiotherapy, surgeries, palliative care have been interfered with because too much focus, rightly, is on COVID. But we need, from a rights perspective, question whether state parties are taking their non-COVID duties as seriously as COVID. Legal entitlements do not work on a seasonal basis, that this time we will only deal with the rights of people living with COVID. We have to holistically expect governments to look after the rights of all persons who are right bearers in terms of the right to health. Also, oncology nursing staff and palliative care specialists were assigned to COVID-19 wards. There is still a lack of ICU beds for post-operative cancer patients. Lockdowns, we heard from Dr. Bello as well in Nigeria, resulted in severe transport interruptions to cancer centers, resulting in people presenting later than normal. So we cannot go with the notion of late presentation. We should, in this instance, frame it as states' failure to adequately protect other rights that are non-COVID specific during a pandemic. So if you don't make provision for cancer patients, of course, there's health entitlements will fall by the wayside. And another important factor is that cancer patients suffered mental health illnesses, which were caused or worsened by the pandemic. You can imagine living with your cancer and not being fearful to go for treatment, or being unable to go because of systemic barriers. So I want us to, in the interest of time, I'm going to quickly talk about some of the ethical issues that have come out as a result of COVID. In a country like South Africa, COVID has exposed glaring health disparities and health systems failures. I was just looking at the turnaround time and the cost of having a COVID test in the public versus the private health sector. A private health sector patient, which is about 14% of the population, who can afford the 900 Rand for a COVID test, will get their results in 2 days. By contrast, a public health sector patient will get a free test, but because there's huge demand, because people are reliant on the state, the results also take longer to be available. And then I want us to reflect on the notion of self-quarantine and looking at it from an inequality basis. Middle and upper income people are able to self-quarantine in the luxury of their homes. But the indigent people, which is about 80% of the population, are not able to self-quarantine because many live in suboptimal housing. And so when you have to self-quarantine in suboptimal housing, living with many people, it becomes difficult. And you start being challenged by the underlying determinants of health, things like lack of access to clean water, lack of access to sanitation. So people are dealing with COVID and all these other social stresses that have been worsened during COVID. But I thought we should be hopeful and look to the future. One of the ethical issues I wanted us to reflect on for a minute or two is the issue of who is going to have access to the COVID vaccine when it finally gets available. We know that rich countries are hoarding it, but let's assume that it comes to Africa, especially to South Africa. How would we allocate the vaccine? And a vaccine that works is a global public good, but in the context of the middle to income country level, there's going to have to be prioritization of this scarce resource. We're going to rely on 3 fundamental values, and those values being the benefit and minimizing harm, prioritizing the disadvantage, and equal moral concern, which means countries will receive the COVID vaccine on a proportion to the population size. The other issue is going to be the use of a distributive framework that must be seen to be morally legitimate, especially since we're in a pandemic. The allocation must follow the principles of procedural justice, transparency, fairness, and evidence-based justification. In South Africa, health workers are going to be the highest priority, followed by citizens with comorbids who are at increased risk of severe death or severe disease. Also, the third group will be people with other comorbidities, especially the ones that I mentioned who live in overcrowded settlements. The vaccine rationing process is going to have to be fair, that there is no differential between the private health sector patient and the public health sector patient. It must withstand the objectivity scrutiny, and the goal must be to ensure accountability, equity, and fairness. access will not be based like it is with getting your tests in the private health sector. Access will not be based on the wallet size, but it will be based on equity and fairness. And there will be fair allocation to quell the rising incidence of vaccine hesitancy and mistrust in science. Thank you very much.
Thank you very much, Kwanele, for putting the ethical stance that we should be considering currently and also moving forwards. I think we've got time for one question. I believe there is a question in the chat. Question for Dr. Asante. Do you think the pandemic will help improve UHC? I think that's universal health coverage for cancer, or make this even more difficult across African countries? So
it is my hope, like Dr. Bello said, at AORTIC we are advocating to bring the rights of cancer patients on the continent to the African Union, because cancer has suffered from the misperception that it is too expensive to treat, and as a result, it is put at the back burner of the national health budgets. So we are seeing cancer being severely disrupted at the moment because of COVID, and I hope that as more and more African countries adopt universal health coverage, which it must be to ensure that the right to health is realized, there must be equity and fairness and equality of opportunity. So I am hoping that COVID is going to be that disruptor, that it's going to make everybody sit up. The fact that we are even having this conversation is very important.
Thank you very much. I'd like to thank you all for participating in this London Global Cancer event. Time is against us. There are several questions which we don't have time to respond to. We started off with Dr. Bello Abubaker telling us about what's been happening in Nigeria. We then moved on to Tariq and Yehoda Martei from the States, telling us about the research that they had conducted in terms of the COVID response in Africa. And we concluded with Kwanele Asante in terms of the ethical considerations with regards to cancer care and COVID applicable throughout the continent. It's now 30 seconds before 9 o'clock. We've been asked not to overrun because there is another session starting. So I'd like to thank all the presenters this morning for their wonderful presentations and enlightening us as to what's been happening in Africa, particularly sub-Saharan Africa. And thank you to the participants for using the chat. There's been lots of to and fro and lots of very good ideas as to how we may move forward as a continent. It just remains for me to thank the Secretariat, who've done a sterling job in supporting this session. And I wish you all a happy day and stay safe. Thank you very much.
Thank you indeed, and enjoy the rest of the day. Thank you. Thank you, Frank.